But I'm very pleased now to introduce some worked examples of sort of mixed methods and approaching this attempt to integrate different disciplines during outbreaks. And we've got a lineup of 3 speakers for you. Very thrilled to introduce the founder and director of Anthropologica. Juliet's also a fellow at LSE, London School of Economics, in the UK, and heavily involved in the social sciences in humanitarian action platform that you no doubt will have heard about and seen lots of resources posted from. So over to you, Juliet. Looking forward to it.
Thanks so much for that introduction, Sarah. It's a real pleasure to join you this afternoon. It was an exciting agenda when it was sent through to me, so I'm really glad to be able to participate. I have got some slides which I can share afterwards, but I thought rather than going through those now, I would just speak to you instead, if that's okay, and then keep an eye on the questions if there are any questions coming up during the 10 minutes that I have, and then maybe the slides can be shared if it would be helpful for a resource afterwards. So I'm taking a slightly different approach from that of the speakers we've heard this afternoon. So to give you a little bit of background, I am the director of Anthropologica. We are a research-based organisation that specialises in applied anthropology and global health. And that word applied is very important. And I think by the end of my 10 minutes, you'll understand why I really emphasise that. The work that we do with Anthropologica is really looking at how we can create a much stronger qualitative and mixed methods evidence base to be able to feed that back in to shape policy and programming and strategy on the ground, with the aim that health interventions, and I mean health in the broadest sense, are as contextually relevant and as appropriate as possible, with the ultimate aim that that will increase timely utilization of services and therefore have a positive outcome on health impacts, or a positive impact on health outcomes. Obviously, that is a very long trajectory, and we don't always manage to work across the whole of that trajectory, but that's sort of the aim and the intention in the approach that we take. We work across sort of development and humanitarian nexus and have a particular focus in working in health emergency, both in terms of preparedness and response, and sometimes also in sort of recovery phases as well. So Sarah also mentioned the social science and humanitarian action platform, and I'll put a link into the chat when I finish speaking, so that if you're not familiar with SHAP, you have access to that website. Anthropologica was a founding partner of SHAP. We set it up with the Institute of Development Studies at the University of Sussex, and with the London School of Hygiene and Tropical Medicine, initially with some support from UNICEF, but over the last couple of years with support from the Wellcome Trust and the FCDO in the UK. And it really came about after the end of Ebola in West Africa. Now, you will all be familiar with this, and you've heard other speakers talk about sort of West Africa a lot already today. I think what that really shows is that although social sciences had been used within health emergencies for decades, what the Ebola outbreak in West Africa did was really to give traction and to give visibility to some of the work that social science was doing, and really to sort of give a space for us as professional social scientists to really try and refine and hone our professional discipline to make sure that it was fit for purpose to be working in the very sort of pressured environments that you are within a health emergency, both taking into account some of the ethical issues that we've just heard the previous speakers speak about, but also from our approach using sort of very applied anthropological or applied social science methods to really be putting the response at the forefront of the work that we are doing. And again, this is where the applied anthropologist or applied social scientist comes into bear, because most of the work that we do is heavily focused on being applied, on being operational, of being of significant use to colleagues in the field and to those who are working at a response, both in terms of globally, regionally, nationally, and then at field level as well. So I think there are three key areas where the work that we do really makes a contribution. The first is around understanding the context, the key features of local context and their direct influence on strategy and implementation of a response. And by local context, and I think maybe you touched on some of this yesterday, I'm thinking through issues like local etiologies and explanations of illness and disease, interpretations of health and health seeking, local funeral, burial and mourning practices. Obviously, that was something that was of fundamental importance during Ebola, and we saw that again in the recent outbreaks in DRC and Guinea as well. But also looking at drawing on understandings of the political situation, of local governance structures, of local forms of public authority, looking at conflicts and insecurity, negotiation, resolution practices, trusted channels of influences and trust, and trusted communication. We've already heard that mentioned again, and I'm sure all of you are familiar with that in terms of your own work. So drawing on some of those very sort of standard socio-cultural dynamics, looking at ethnicity, of clans, of religious affiliations, but also looking at livelihoods and economic situations, of mobility patterns, which can obviously have a huge impact in terms of the transmission of a disease in and out of at-risk and affected areas, looking at sanitation practices and sanitation structures, food sourcing, and obviously really trying to take a lens, a gender-based lens to all of these different types of structures. So there's lots of different components that make up local context. And a lot of the work that we do is about trying to understand those features and how they will shape not only the transmission of disease, but potentially shape the response itself and the effectiveness of the response. The second area is around how we can tailor standardized components of a response to the local context to make those interventions as acceptable and as appropriate for the at-risk and affected populations as possible, bearing in mind that they are already under a huge amounts of stress and pressure. And by tailoring standard components of a response, I'm really referring to things like standard operating procedures. I'm sure all have the experience of working with colleagues who technically are very good, come from a very strong public health background, know how to get on top of a cholera outbreak, how to do contact tracing for an Ebola outbreak, looking at how to really focus on sort of yellow fever in a very complex setting like Angola. But oftentimes we find that colleagues who are coming in, particularly from the international level, but also from the regional and national level, perhaps whilst they have that technical public health expertise, they have never worked in that particular country or that particular region of a country before. And this was certainly very much the case in DRC with the Ebola outbreak back in 2018. So a lot of the work that we help to support is how can we take those standard components of a response, those standard operating procedures, and really drill down into what is needed at the local level, at the community level. The third piece, perhaps is the most important, and that's around operationalizing social and behavioural data that is gathered during the response and how we can use that as an evidence base to help shape these actions on the ground over time. The reason that I wanted to speak before Simone is that I think she's really going to pick up on that third component about how you gather data, how you operationalize data, and how you convey that into a response in a timely fashion, by really taking you through the work that she has been developing with IOA. So I'll leave Simone to really focus on that piece. But in terms of research, just in the last few minutes that I have remaining, what I really wanted to emphasize today was we never work in a vacuum, right? Wherever the outbreak is happening, wherever we are working with vulnerable or at-risk populations, it's almost impossible to imagine that we don't already have information to some degree about that context and about that environment that we're working in. So a lot of the work that we do with SHAP is about how to mobilize that existing knowledge. So it's not always necessary to jump in and be doing fresh data collection and fresh research on the ground. Actually, what we can do is do a lot of that work remotely. And some of that is very much orientated towards the pre-positioning of social science intelligence. So what can we do during a preparedness phase? And then how can we quickly surge? How can we quickly mobilize to really look at what is already known? What are those known knowns about the socio-cultural environment, the broader context that I just mentioned? How can we anticipate what some of the issues may be? And then importantly, how do we mesh that existing knowledge with emerging issues on the ground so that it is kept very relevant and very time bound? So sometimes it is necessary for us to do rapid research. And of course, there's many different types of research. And I think from Sarah's introduction, you really focused on that yesterday as well. But in addition to the different disciplinary types of research, there's also sort of good enough data, which is, you know, rapidly connected, some people call dirty data, indicative data, which gives you sort of quick answers and a quick guidance, quick direction here and now, all the way through to longer term, more rigorous research. And I don't see those as either or as being in conflict. I think that actually we need to embrace the whole spectrum of those different types of research. But the key is, how do we triangulate that? And then how do we operationalize data? So how do we have this two-way flow of information at the beginning of a public health emergency? Of course, it's necessary to get out messages and instructions around how to protect yourself, what are the signs and symptoms, where to seek treatment. But very quickly, we need to be listening to communities and crucially acting on what we're being told. If we don't act on what we're hearing from communities on the ground, then we risk further disenfranchising those communities, and the response will not be as efficient and as effective as it could be. And so I think we really do have a duty, an ethical duty in this area of work, to be as accountable to the affected populations as we can do. So within SHAP, the way that we sort of mobilize this existing knowledge, as I said, we do it in a couple of different ways. And I just want to touch on a couple today. And then for those of you who may be interested in following up on SHAP, please feel free to reach out to me directly or go through the website, the link that I'll put in the chat window. But we have expert advisory groups who really build on the network that we already have. So when there is an event or an outbreak occurs, we can quickly identify colleagues who have very granular experience working in those areas. So again, taking DRC as an example, not anthropologists who have worked in Africa, not anthropologists who have maybe worked in DRC before, but anthropologists and social scientists who have very long research experience of working within and with those affected communities, and also in some of the areas we know are going to be important for the response, like the cross-border issues. So we can bring together these expert advisory groups and position them so that actually we can feed information into the response to help with strategy. And oftentimes those expert advisors will say, we can anticipate this is going to be an issue that perhaps the responders even haven't thought of yet, being at the front line of a response. So again, this sort of two-way flow of information is very important. So through the expert advisory groups, we often produce a series of briefs, which you may be familiar with, and give verbal briefings as well. But the briefs are all, the written briefs are all open source, they're open access. They're all posted on the SHAP website, but on other websites as well, like ReliefWeb and ALNAP and others. And then a new initiative I just want to touch on really quickly is around the technical assistance workshops that we are now offering to partners in the field, because so often we've heard people say to us, we understand the importance of social science, we know what we want to be able to get from social science, but we don't quite know how to do it. So we have put together a series of technical workshops which are very bespoke. They work with particular organizations, particular problems in the field, and really help to sort of build that capacity of how you can look at what we already know, how we mesh it with emerging issues on the ground, and then how we can best, from working from a remote perspective, support colleagues like Simone, who are really at the front line and collecting data during a response. So I'll pause there and either pass back to Sarah or pass directly to Simone, as you prefer.
Thank you very much indeed. Yes, if we could take some questions at the end. So I'd be very pleased to hand straight on to Simone. Simone Carter is the lead for social science analytics cell in UNICEF, and she's based currently in the DRC. I think you're going to talk to us about integrated outbreak analytics.
Thanks. Yeah. Hi, everyone. So actually, I lead integrated outbreak analytics. The outbreak analytics in the DRC for the last 4 years, and I lead on integrated outbreak analytics for the public health emergencies team in UNICEF. But first, we're actually going to share a little animation. So I don't know if that's great. Thanks, Alex.
Analytics, or IOA. When investigating a disease outbreak, the first information that we look for in classic epidemiology is person, time, place. That is, who is affected, when it is occurring and how quickly it is spreading, and where it is spreading. In addition, we ask what pathogen causes the disease and what is the clinical impact. That is, what are the symptoms, and are the symptoms so severe they lead to hospitalization or death? This paints a basic picture of the outbreak, but it doesn't give us the whole picture. For example, it doesn't tell us why some people are more affected than others, or how families and communities may be reacting to the disease or response interventions. IOA, or Integrated Outbreak Analytics, is an approach to better understand outbreak dynamics. IOA tells us why a disease occurs in a particular location or community at a particular time, and how the disease as well as response activities affect the communities. A better understanding of the perceptions or behaviours of communities might help explain why they are at increased risk. Surveys, interviews, or focus group discussions are all good ways of gathering this information. Knowledge about pre-existing health risks or vulnerabilities, such as vaccination status, might also explain why we are seeing peaks in certain communities. This data is provided by health facilities or national health information systems, such as DHIS2. It is also critical to find out whether healthcare workers have the knowledge and capacity to diagnose and properly treat the outbreak disease. This information is found in healthcare programme reports or by performing surveys with healthcare workers. We should also investigate events or local context that could be related to the outbreak. For example, was there a rupture in vaccine supply or new policies implemented? This information can be found in local health programme reports, newspapers, or social media. Finally, it's crucial that we consider social and gender norms, such as who is responsible for treating the sick at home. Such norms may put certain communities or individuals, such as women or the elderly, at higher risk. Such information is obtained via healthcare programme reports, anthropological studies, qualitative interviews, focus groups, and discussion with staff and teams. Even though all this information comes from different sources, they are interconnected. They help us to see the various influences on outbreaks. IOA recognises that these factors may differ from place to place, and therefore is always performed at the local level and in partnership with local ministries of health and stakeholders. To find out more about IOA, please select one of these videos.
Simone, would you like to play the subsequent video?
Yeah, we can do one after other.
IOA is a multi-actor and multidiscipline approach. IOA, or Integrated Outbreak Analytics, includes collaborations with partners in support of ministries of health and governments. Contributions may come from local health actors, national or international non-governmental organisations, UN agencies, academic institutions, or civil society. Contributions to IOA could be in data collection, data analysis, evidence-based decision-making, or training and capacity strengthening. IOA analyses multiple data sources, some pre-existing, some newly collected. Depending on the data source or type, different methods for analysis can be used. Surveillance and healthcare service use data may require statistical analysis. Qualitative or contextual data may require coding by hand or using a qualitative analysis software. Some data are best analysed in mathematical models, while others require maps. Let's look at an example from the 2018-2020 Ebola outbreak in the eastern part of the Democratic Republic of Congo. During the outbreak, the Ministry of Health set up an IOA cell, or a team that included national and international experts. The IOA cell investigated higher than expected numbers of children aged under 5 years infected with Ebola. Healthcare data showed that children were quickly brought to healthcare facilities, but that the Ebola was not quickly diagnosed. Interviews with the parents revealed that many did not recognize the symptoms as Ebola. Similarly, surveys conducted with healthcare workers revealed that many found it difficult to detect symptoms of Ebola among children. So there was poor recognition of Ebola in children by parents and healthcare workers. Meanwhile, healthcare data indicated that there had been a large increase in service use by children, meaning that children were sharing beds, potentially with Ebola-infected cases. Data from the Infection Prevention Control Programme reports highlighted that over 50% of healthcare facilities did not have the required resources to prevent Ebola transmission. With all these different data sources, the IOA cell was able to attribute some of the higher than expected numbers of Ebola in children to child-to-child transmission inside healthcare facilities. This information enabled outbreak response actors to take specific and targeted actions quickly. These included improved training and health promotion for recognizing Ebola symptoms in children, and increased resources for prevention of transmission, such as promotion of vaccination for children, decontamination, and reduced bed sharing. To find out more about IOA, please select one of these videos.
Do you want the third?
No, I mean, that's up to the group, really. We have a third video. If it seems like that seems to be people are enjoying, so I'm much happier to just let the third video play through, if that's the group, of course.
IOA approach for decision-making in public health emergencies. IOA improves responses to outbreaks through a more holistic understanding of an outbreak at the local level. Some of that evidence may come from analysis of pre-existing data sets. However, some questions may require the collection of new data in a study. For the study, terms of reference will be developed. This includes the question that will be answered or the objective, the sources of information and methodologies to be used, and most importantly, how the results will be used. If we cannot define how the information will be used or by whom, we won't do the study. This process ensures that all stakeholders are engaged from the start and the study is approved by the Ministry of Health. The data collection then takes place and analysis is done using the multi-data, multi-discipline IOA approach. Presentations are then prepared that may be in the form of a report, visual presentations, or direct discussions. The presentations are adapted for different stakeholders, including local healthcare workers, civil society, outbreak response actors, and government actors. And the aim is to co-develop recommendations which may inform strategy, interventions, or funding proposals. We then document what recommendations were agreed, who is responsible for their execution, appropriate indicators, and feasible timelines. To find out more about IOA, please select one of these videos.
Thanks very much. I think I don't have much more time, so maybe just very quickly I put in the chat. One of the things that happens is really because we're working physically all the time, working with partners, working with the Ministry of Health, everything happens in near real time. So collection, analysis, and use of data can take as little as 1 week or as much as 1 month, but depending on the question, the study type, and the urgency. But that happens because of the fact that we're here and we're working in constant collaboration. We're not always collecting new data, and we have access to these different data sources with big thanks to the different partners who participate in this. So I'll just stop there. Thanks so much.
Very pleased, Irene, to hand over to you. Remember, Irene is a fellow working in information and communication technologies. She's based at the National Institute for Medical Research in Tanzania. So over to you.
Thank you very much, Sarah. I hope you can hear me now.
Yes, absolutely. Hello? Yep, you're good to go.
Yes, allow me just to put the video for a short while. The internet is not so very good, so I will definitely, after this introduction, switch off the video. I hope that will be fine. Yep. So I'm glad and happy to be in this forum and this workshop, and I will share part of our experience and the value of integrating social media surveillance and digital technologies in the health research during the epidemics. So now allow me to switch off the video. Quickly, I will go straight to the topic that I've been given. As we all know, that of recently there have been witness of digital revolution in the public health and the global health in general. And for this case, the social media surveillance and digital technology are being harnessed to support the public health surveillance system globally. And we can see the example of Health Map and ProMed that have been used by WHO, but also the social media and the digital technologies has been a good in better communication among the sectors and broaden understanding of causality, but also support the communication with the public. And with this new opportunity, it has really enhanced the easy in disease outbreak detection, tracking, prevention, and reporting, and as well as analysis as we use the advance of ICT techniques. So I will briefly try to show the value of the social media surveillance and digital technologies. And in particularly for Tanzania, there are some applications that have been used, and I will talk of the AFYA data and the mobile AFYA that have been used to communicate and report infections and outbreaks in the community. And this has really helped, as it has been a means to report what is really happening at the community level, as well as the use of mobile AFYA. And all these two applications, they really send the information to the district level, to the actors, the district level and the health facility as well. And for this case, I will quickly take you through the early integration of data to the surveillance system. And this was a case of cholera in our setup. And as you can see from the community health reporters, here we use the AFYA data and we use the WhatsApp platform as well. So the community health workers in these areas, they have smartphones and they can send information straight to the cholera treatment camps, but also to the health facilities, as you can see. And whatever information that are sent as a suspect of outbreak or any infections in that particular community goes straight also to the DMOs, the district council, and those who can directly work to the community. But also the information are linked to the master registers, as you can see, after they have been analyzed at the district levels. And from there, the interaction can have all the maps, all the details, as well as knowing where the outbreak has happened. So for these cases, it promises the faster reporting of the disease outbreak from the source. And it has improved the public health surveillance system by providing a better information and an early warning. As I said, it is also integrated on the it is also integrated on the surveillance system that are existing, and into this particular is the IDSR through the DHIS2, and it has been a support to the improve of public health concern. The social media surveillance has also been useful to the reach of the targeted populations, as I've said, that millions of people now have mobile phones, and it has really helped on the intervention and interaction with the community, and that's to say, improve the health outcomes. It links the social sciences, the use of technology. We saw from the previous presentation yesterday on the geospatial information. We saw from the presentation just on the integrated outbreak analytics that has been presented just shortly. So all these, it has been an essential things for linking the social sciences as well. Just from the very current study that I have done with the team, we did a review that trying to see on the time that we had the 20 years of integrated disease surveillance, the existence of IDSR in sub-Saharan African countries, and we check on the challenges, opportunities for the effective management of the infectious disease epidemics. And onto this study, 45 studies were involved, and we managed to see that there is a need for a platform, and here is where we proposed a national platform for multi-sectoral, multi-disease, and multi-indicator, and we call it 3 M's for the epidemic intelligence system. And we are sure that having this platform, it will help to consolidate all the existing surveillance system to define composite surveillance indicators, and with intelligence to trigger and guide response to the public health. So as you can see from the figure of the proposal, we show all the data sources that are available, but they are all not integrated. They are all working on their own. So having all these speaking in one platform and see a way to have a proper actually technical communication and data processing, but also designing the analytics for that, it will really help on early warning alerts. It will give effective response to the public health. It will be giving the spatial, but also we'll be able to see the demographic, social, and economic factors easily identified in one platform. The takeaways, a key message is it's essential to have the social media surveillance and digital technologies in One Health research during the epidemics for an effective transdisciplinary interconnection among human and animals and the ecosystem. And it's high time to embrace the value and the importance of the digital technology so as to enhance the integration of the social and life science in a one platform, so that we can really implement the One Health research during the epidemics, but also the social media surveillance digital technology cannot operate in isolation. Most of the time it comes like not done in parallel with the life science, with other research science. It is normally done on its own, and that will really not improve the existence of the public health care system, but we need to integrate it all together. Thank you for listening.
Thank you so much. That was absolutely fantastic. Loving that picture that you've got there. So yes, it's wonderful to see that you're doing so much work up in Tanzania. And I think we've got one question in the Q&A feed, but this is for Simone. I mean, we've got lots of comments in the chat saying how much people are enjoying the presentations. But Simone, if you're able quickly to answer this before we have a very short break, is there a difference between integrating social sciences and analysing the data in an integrated way?
Ok, il y a une différence entre la recherche intégrée et les analyses intégrées. I mean, I guess it depends a little bit on how you look at it. I mean, so basically,
yeah,
so
I guess okay.
So for example, if you were doing modeling, you could decide, okay, we're going to include social data into a model. So actually, recently, there's some publications on this, on what it looks like to include more social behavioral data into epidemic modeling. So that's one way to do an integrated analysis in that sense. But there's also the concept of saying, okay, we're going to take a whole bunch of different data sources, which have potentially been analyzed already in their own way, and bring them around a table and do this kind of like, how are they speaking to each other and analyzing them. They've first been analyzed separately, collected, analyzed separately, and then we're bringing them together and analyzing them in an integrated manner. In terms of language, I think that depending on who you ask and what their expertise is, we're always going to use different words or different languages about that. And I don't think that there's one better or worse way. I think maybe what is really important is that we go, what are the information needs that are required to make an appropriate decision to inform health or outbreak response? Based on the information needs, we know what kind of data we need to collect. Based on that, we know what kind of methods we need to be using. And always keeping the lens of going, how do we look at this holistically, not just in the outbreak, but the potential impacts that the outbreak response might also have. So I'm not sure if I fully answered that question, but there we go.
Yes, you made a very good stab at it. Yes, do you find that there's much opportunity to coordinate the data collection for efficiency purposes? So where you do have different needs, yet you're sending, a group out into the field, would you be able to collect all the data that everybody needs at the same time, or are they sort of usually done as separate projects and then coordinated at the end?
That's a great question. So no, I mean, so it's very, again, we focus very much on operational. So we get a question. So for example, recently we've been asked by polio teams. Polio has tons of data, but they wanted to understand why there have been particular areas where there are lower vaccine uptake. So we have program data on where there's a gap, right? So first we have that data, and the polio teams come to us with the Minister of Health, and they say, we have this program data that shows that there's a gap. Then they say, and we say, okay, well, what other data? And this happens within 2 days. We get all the actors together, everybody working on polio at a national level, because that's where the request came from, because they noticed particular provinces at a national level that were lower. So we say, okay, what else do we have? We take DHS2 data, and that shows us, do people in those same provinces have other lower vaccination uptake comparatively? And then, or do they have lower healthcare services use? Have they had, maybe less children born recently, and that's why they have less vaccination rates? So we look at that again very quickly, because that data we're systematically analyzing and making sure it's always available. Then we take all the other data really, again, like we said, we have 3 meetings very quickly, because before the next campaign, they need us to do this. Then the teams go. We have teams there. They rapidly work with the local health actors to agree on a data collection method and tool that everybody says the way that we're collecting additional information to respond to the question will be used. But those questions vary a little bit. So it's not just do you refuse a vaccine, but it's what is your access availability, working with healthcare workers and communities. And then we do quickly data collection, representative sampling even, and presentation analysis can happen within a week. But that is because we work and we have those relationships built with the Ministry of Health. So we're not sending in international teams. People aren't doing big research projects. It's really about working at a very operational and local level. Data were collected, presented, analyzed at local level with community healthcare workers first. They validate, and then we bring it up. National level, we haven't presented yet because they do it first there. They co-develop actions first there, and then they agree on the action plan, and then we talk about it at a national level. So I hope that helps.
Absolutely fabulous. Yes, you must be constantly on standby, if not very busy. I think it's fair to say. So thank you ever so much indeed for all of the presentations this afternoon. Yes, I've learned a lot. I hope everyone else has too. So we have time for a very short break, only 3 minutes, I'm afraid, if we're going to fit in the interactive activities. But while we're having a quick stretch, could I ask Adam to post up the slide about the different activities? And Sarah, if you're able to post the link in the chat to the survey.
Yes, sure.
So an expression of interest, so that in due course, if you're interested in taking part in later consultative efforts as described this morning and as we're about to post up again on the slide, so as to inform some of the policy making in using and integrating social sciences. And we've certainly got a fantastic model in the form of the integrated outbreak analytics and the work of others. But please, feel free to fill out your expressions of interest. And it would be marvelous to be able to coordinate some of these activities with the speakers and possibly also, collaborate in a much sort of wider effort still for the benefit of the African CDC.